Hello. I'd like to welcome everyone for joining us today for Ask a Radiation Oncology, a radiation oncologist session focusing on cervical cancer. I'm Jenna Kahn, and I'll be moderating this session as a representative of the ASTRO Communications Committee. I'd like to start out by thanking the ASTRO staff, particularly Jeff White, Danielle Mulligan, and Beth Bukata, for helping to facilitate this event. We have a distinguished panel of speakers who volunteered to share their experience in cervical cancer with us today. This includes Ann Klopp from MD Anderson Cancer Center in Houston, Matt Harkenreiter from Loyola University in Chicago, and Jyoti Mayadev from University of California, San Diego Moores Cancer Center. Thanks to each of you for being with us today, and for all the hard work you've done as leaders in clinical research and patient care that has improved the lives of many patients with cervical cancer across the country. Next slide. Next slide. So the format for tonight will be the panelists will answer prepared questions, we'll have questions in the Facebook chat. We'll be recording this, which will also be online. Next slide. Next slide. This is a representative of our brochure that's on rtanswers on .org under gynecologic cancers. There is the brochure online that you can download as a PDF and go back to read up on gynecologic cancers. Next slide. Also on rtanswers.org, you can watch a video on gynecologic cancers that goes through what radiation therapy is in gynecologic cancers. Next slide. This is where you'll land on rtanswers.org. On this page, the first line, you click down to select a cancer type and you would click on gynecologic cancers. And you can also find a radiation oncologist by searching city. Next slide. So we'll get into discussing cervical cancer. So first, next slide. We're going to talk about what is cervical cancer. Dr. Harkenreiter will discuss what cervical cancer is.
Thank you, Dr. Kahn. So thank you all for joining, and thanks for the opportunity to be part of this distinguished panel today. So cervical cancer is a malignancy, a cancer of the cervix, which is the lower part of the uterus. So we can see a nice normal anatomy illustration at the upper left part of the screen with the ovaries as the kind of ovoid structures off to the left and the right, the tubes then that connect them to the uterus in the center part of that image, and then the lowest part of the uterus is the cervix, and then we see the vaginal canal extend at the lower part of that image. So this is a cancer of the lower part of the uterus there. It's visible at the top part of the vagina. So this is why examinations are important in case the gynecologist can see an abnormality or feel an abnormality on the routine examination. The lower parts of the image show a progression of stage for cervical cancer. So all cancers are given stages, most commonly stage 1, the earliest, stage 4 to the most advanced. And this shows an image of cancer slowly enlarging so that it's visible. That's the second image on the left, where you can see some abnormality at the bottom on inspection, visualization of the cervix. And then the third image from the left on the bottom is more extensive involvement of the cervix, again, still limited to the cervix itself. And then the image in the bottom right is once the cancer has kind of spread to the adjacent nearby tissues, indicating more advanced disease. So these are all things that the gynecologist will be looking for if an abnormality is seen or felt on the cervix.
Thank you. We can go to the next slide. So what is and what are the causes? Like, what is HPV? How do people get HPV? Dr. Klopp.
Sure, yeah. So cervical cancer is somewhat unusual cancer that is caused by a virus. The human papillomavirus is spread by sexual contact. It's actually a very common infection. So 80% of every person will get infected with the HPV virus in their life, but only for a very small minority of people will it turn into a precancer, a dysplasia, or a cancer. So there's a very effective vaccine, the HPV vaccine, and kids from 11 to 12 can get the vaccine, and up to age 45. And the vaccine will prevent the HPV infection from happening. And so it's a really effective way of preventing the precancers or cancers that we treat with radiation. So I really strongly recommend it for everybody to consider for themselves or for their kids.
What about for males versus females and getting the vaccine?
Right. Well, because men also can get HPV infections, it contributes to other HPV cancers. It is also effective for men. It's not yet approved for men in different age groups like it is for women, but we have every reason to think that it is effective. Well, I should say actually, it is approved for teens, male teens that can get the HPV vaccine to prevent them from getting HPV cancers as well.
We can go to the next slide. So Dr. Mayadev, is there anything you can do to prevent cervical cancer, and how does screening work?
Yeah, I mean, cervical cancer is really one of medicine's greatest, I would say greatest hits, in the sense that we have a way to prevent it through the HPV vaccination program. We have a way to detect it, an early detection for better cure rates through screening. And the screening, Pap smear, has really been the greatest cancer screening program in all of history. When we look at, the Pap smear is really invented in 1928 by Dr. Pap, after, looking at swabs of vaginal cancers and seeing some what we call atypia. And in general, if you look at the screening cancer rates in, say, 1975, when about 14 patients per 100,000 were presenting with cervical cancer in the US, and then the advent of the Pap smear and patients becoming really aware of the Pap smear, and the cervical cancer rates dropped precipitously. If you look then around 2015 to now, we have about half that rate, so about 7 or 6.8 per 100,000. So there is a way to prevent cervical cancer through the HPV vaccination program, and there is a way to detect it early through the Pap smear. And a Pap smear works like in this diagram Dr. Khan had put together. You visit your provider, your GYN provider, primary care doctor, nurse practitioner, allied health professional, and they'll do a speculum exam, and they'll just take a sampling around your cervix. And that sampling will then go to the lab to determine whether you have some atypia or pre-invasive cancer. And so there are some new kind of techniques trying to offer patients in lower income countries self-sampling. And so we have a lot of options in the future. In terms of screening, the American Cancer Society just updated their guidelines. And I think we're going to talk about that in the next couple of slides, or I can talk about that now.
Let's talk about that now.
Okay, yeah. I mean, if you look at the various screening guidelines, they have changed over time. And so the American Cancer Society just published a year ago, 2020, their guideline for screening recommendations. And for women 21 to 24, we used to recommend a Pap every 3 years. That's changed. Now we actually don't start screening until the age of 25, and that is with an HPV test. HPV and a PAP test can be something called a co-testing, an HPV co-testing with a PAP. And if the patient is HPV negative, they can actually push their screening interval to 5 years. So we know that HPV testing is actually more sensitive, or it picks up pre-invasive cancer earlier than a pap smear. And that's why it's become so much more important. Women between the ages of then 30 to 65 get the co-testing, and they can be screened every 5 years. And above 65 without high-risk features, women can actually, if they've had a negative pap or a negative HPV, can actually stop the screening process for cervical cancer.
That's great to hear. When we talk about if you get an abnormal pap smear, what would be the next steps, Dr. Harkenreiter?
Right. So if you, when you get those cells scraped by your provider, like Dr. might have said, they will get analyzed under the microscope at the lab. This image kind of shows the normal cells on the left, but what they're looking for is some abnormal cells that may require you to have a little closer follow-up with your provider, repeat testing, or potentially have something done as a preventative measure to try to prevent cervical cancer from forming. So this kind of shows the spectrum of cells ranging from normal to cervical cancer. And there's these intermediate cell levels of low-grade squamous intraepithelial lesions. So some early abnormal cells. And then HSIL is high-grade squamous intraepithelial lesions. So some more ugly cells that has a greater potential of moving on to cervical cancer. Now you can see that the arrows can go back and forth. And that's part of how your body reacts and can kind of clear an either HPV infection, or that those abnormal cells can resolve themselves. So if some of these abnormal cells are visualized, then your provider may call you back for an additional test called a colposcopy, in which case some vinegar solution is spread on the cervix that may find an area that looks a little bit more abnormal that warrants a biopsy. And so that's all part of the process for screening and early detection of some of these spectrum of abnormal cells, so that hopefully we don't get to the point of having cervical cancer.
Thank you. I haven't seen any questions come in. Any additional comments about the detection or screening of cervical cancer from our panelists?
I could make a couple comments, before the questions come in. No online questions. Okay. So, a lot of our patients and community outreach have asked, what is the screening rates for cervical cancer across the country, and how have they been affected by COVID? And when you look at, there's been, some data looking at our cervical cancer screening, and in the United States, it actually hovers around 78 to 81%. So, not great, for women who have access even to healthcare. A lot of this data was actually from the California Kaiser Permanente, who collects a great database. And there was a recent publication about what's the impact of COVID and how did that change our screening? And unfortunately, it actually dropped the cervical cancer screening significantly. So we know that it actually dropped it by more than 30%. So, we want, patients in the community to know that, it is, in good hands with your healthcare provider. They're taking an abundance of caution with COVID. We still encourage you to get your annual screening. If you're higher risk, or according to the American Cancer Society, at least every 5 years with the HPV co-testing or HPV primary testing.
Thank you. A question did come in, and it's a great question that we didn't have an original slide on, but Dr. Harkenreiter has a slide on, is how to preserve fertility. Is there something that you can do to preserve your chance for children in the future?
Sure. So I think that we have a slide on this coming up, but there definitely are options for fertility preservation, especially when the disease is caught early enough. So Dr. Khan, if you want me to comment on that now, otherwise it's, I think,
yes,
a couple slides from now.
Yes, we'll get there in a few slides. So let's move on to the actual treatment for cervical cancer. So who are the doctors that are involved in cervical cancer treatment, and what does each provider offer? Dr. Klopp?
Sure, yeah. So many times cervical cancer is diagnosed by gynecologists, who may be the ones that are seeing patients that come in either for a pap smear or for evaluation of a symptom. When a patient is diagnosed with cervical cancer, they're typically referred first to the GYN oncologist, who's a gynecologist who's undergone special training to treat patients with gynecologic cancers. And then if it's a cancer that will be treated with radiation therapy, then typically patients are referred to a radiation oncologist. The gynecologic oncologists, they do surgery, and they also prescribe chemotherapy treatment. So the treatment for locally advanced cervical cancer is typically a close partnership between a GYN oncologist and a radiation oncologist.
Thank you. Can we go to the next slide? So what are the different types of surgical procedures that can be offered for cervical cancer? And is laparoscopic surgery any better than standard surgical procedures for cervical cancer, Dr. Mayadev?
In terms of curative therapy, there are the standard options have actually changed for surgical procedures. Right now, we still, off of the clinical trial setting, do a lymph node dissection in patients. For early stage patients, there can be fertility preservation with something called a radical trachelectomy, which just takes the cervix and the areas slightly around the cervix. The fertility rate after that is still only 50%, so knowing that going into it. The other types of procedures include a modified radical hysterectomy, and this would be considered the standard. It used to be a radical hysterectomy, but there's been some recent data actually suggesting that there's variations of the modified radical hysterectomy. In terms of laparoscopic versus open procedures, this actually has been quite a very interesting question, because over the last several years, there have been significant amounts of randomized trial and data coming out that show that laparoscopic surgery for patients with cervical cancer has worse outcomes than open procedures. So right now, based on the randomized data that actually Dr. Klopp's group at MD Anderson headed up in terms of an international trial, our group at UCSD has actually moved to open procedures unless there's a surgical reason not to. So again, for cervical cancer right now, we think laparoscopic surgery could be potentially inferior to open standard procedures.
Here's our question on how to preserve fertility, Dr. Harkenreiter.
Great, and kudos to you, Dr. Khan, for the awesome photo that accompanies that. So obviously this is, as we get better and better with our cancer care, preservation of quality of life in many ways is very important. and fertility is such a big part of that, especially for a disease that can affect younger women. And so the options for fertility preservation will predominantly hinge on the stage or the extent of cancer that's found at diagnosis. So if the cancer is found very early, in one of those stages where it may have only been detected microscopically, meaning on the swabs or on the biopsy, then the gynecologic oncologist might be able to do a more limited procedure to simply remove a portion of the cervix or kind of scrape a lining of the cervix. So those can be called a conization procedure or a LEAP, an electrocauterization. In that case, the woman retains her uterus, her tubes and ovaries, and can still bear a child normally. There are some modest decreased risk in infertility, but absolutely remains an option. Dr. Mayadev described a little bit more of a significant procedure called a trachelectomy. That's a bigger removal of the cervix. In that scenario, patients, again, still can maintain fertility, but the rates do go down. When cancer is more extensive, then patients will either require the bigger hysterectomy procedures like Dr. Mayadev described, or radiation treatment. In those scenarios, harvesting of eggs, freezing of eggs, and then utilization of surrogates are our kind of native fertility options. So they do exist. It is a very important discussion to have with patients who are interested in childbearing, but those are the options for fertility preservation. Once radiation therapy is given, as we'll kind of get into, then the ovary function decreases and the uterus is likely unable to carry a child.
And often people can go for egg retrieval prior to doing chemo and radiation if they would like to perhaps use a surrogate later.
Absolutely.
As another option. We can go to the next slide. So Dr. Klopp, why might a patient not want to have surgery to treat their cervical cancer? What are those risks? And why are some patients not candidates for surgery?
Sure, yeah. So the surgery, the sort of classical surgery for cervical cancer would be a hysterectomy, either what is considered just a simple hysterectomy where just the uterus is removed, or a radical hysterectomy where also the tissues next to the uterus are removed. And the side effects of that surgery, it's a very safe surgery in general, but there are of course side effects related to the procedure itself. So obviously, when the uterus is removed, so no longer possible to be pregnant. The ovaries are removed. Patients will have symptoms of menopause. Sometimes patients have urinary side effects, like urinary retention and things like that. The risks are really minimal, though, otherwise, in terms of things like infection or bleeding. So I think the big question is just whether surgery is the right intervention for anyone who's dealing with cervical cancer. And of course, the GYN oncologist will choose the right surgery. And the important factors that are taken into consideration is how extensive is the disease. If it's very small, a very minimal procedure can be performed. And if it's larger, it may be necessary to do either the radical hysterectomy or in some cases, like we talked about, there are even some very sophisticated ways of just taking the cervix out and the parametria so that the uterus can be retained for potential pregnancy in the future. So, why are some people not candidates for surgery? Really two reasons. One is because of the extent of the tumor. So in some cases, the tumor is just too large to be safely removed. And what that can mean is that there could be what are referred to as positive margins, or essentially tumor at the edge of the tissue that was removed. And when that happens, we need to do radiation afterwards to prevent the cancer from recurring. and it can require higher dose radiation. So we work hard to avoid that situation. And then the other reason why somebody could not be a candidate for surgery is because of other diseases. But that's pretty unusual now. Now most people who for whom surgery is the right choice can go ahead and get the surgery they need.
And just to add a question from the audience to that, we had discussed why laparoscopic surgery was worse. We had a question asking, why is laparoscopic surgery worse outcome than the open procedure?
Yeah, that was a really interesting finding. And I think, one thing, it just speaks to the importance of doing research. There's a lot of things we just don't know unless we ask the question, in a rigorous way. And in that case, what was found was really a surprise. That laparoscopic surgery actually was associated with more people that had a recurrence of their cancer. And so, the possibility is that the manipulation during the surgery in such a way made it more likely that the cancer that recurred, and that the process of doing an open surgery is just a safe and more effective way to remove the cancer, essentially.
Thank you. We can go to the next slide. So Dr. Mayadev, what is radiation therapy and how does it work?
Yes, radiation therapy is the production of therapeutic x-rays. So just like you go and get a chest x-ray, that's in the kilovoltage range, and the radiation is actually in the megavoltage range. So it's like a therapeutic x-ray. And it causes, through oxidative processes, direct or indirect DNA damage to the tumor. And so that's how radiation kills cancer cells.
Thank you. Can we go to the next slide? So Dr. Harkenreiter, what are some of the different types of radiation therapy that may be offered for cervical cancer?
So on the prior slide, we saw some pictures of the machine that is used to deliver these high-powered X-rays. The image that we see here shows some of the colorful lines that we often see, but what that represents is radiation dose being delivered in the patient tissue, both in the cervix, but also the nearby areas of the tissues that are off to the sides of the cervix, the uterus itself, but also those lymph nodes, those draining glands. So these machine treatments are often delivered as a daily regimen, Monday through Friday, often for 5 weeks or so. The machine treatment takes 5 to 10 minutes to deliver the treatment, but often you spend 30 minutes or so in the radiation department. But you don't feel those X-ray treatments that are being delivered on a daily basis. The kind of squiggly lines on the left is a more sophisticated type of treatment. It's called intensity modulated radiation therapy. It's more of a shaped radiation. So we're working to really be most precise to deliver the treatment where we need to, but avoid the organs that are nearby, like the bladder and the rectum and the bowels. The more boxy looking treatment in the upper right is treating all that same area, but just isn't quite as shaped to spare the organs quite as well. But there's pros and cons to each type of treatment in that regard. The image on the bottom shows what we would call brachytherapy. It's internal radiation. So often towards the end of the course of the 5 weeks of machine treatments, or after all the treatments have been completed, and a device can be placed into the vagina that has a couple different components. One piece that goes into the uterus, and another piece or pieces that sit right next to the cervix. And treatment can be delivered essentially inside of the tumor. That really helps to give a large dose of treatment to the tumor that is most effective at killing the tumor, but also can decrease the intervening dose that gets to the bladder and rectum. So there's relative sparing of those nearby adjacent structures. And as time has gone, our field has gotten better at how to use imaging and different devices to customize our treatment for our patients.
That's a great segue into the next slide for Dr. Klopp to add anything more about what brachytherapy is and why it's important in cervical cancer.
Yeah, like Dr. Harkermatter was describing, it's a kind of radiation treatment that comes from the inside, and it's actually one of the oldest cancer treatments. It was performed in the early 1900s for women with cervical cancer using actual radium radioactive sources. So the way that we do it has evolved a lot over all those years, but fundamentally the process is the same, that we implant radiation inside of the tumor, and it's a really effective way of getting rid of cervical cancers. And in fact, when we've looked in these studies, this slide on the bottom shows you the percent of women that are surviving free of their cervical cancer in years after their diagnosis and treatment. And you can see in this green line how much better women do when they get brachytherapy. And so we just really want to make sure that all women that are dealing with cervical cancer and getting radiation therapy get brachytherapy whenever possible, because it's just such an effective part of the treatment for cervical cancer.
Thank you. Can we go to the next slide? Dr. Mayadev, can you touch on some of the side effects that are common with radiation therapy, and also touching on the sexual side effects from treatment?
Yes. So I always think of the radiation side effects as inter and related to the areas in the pelvis. So, number one, GI toxicity. So things that affect your bowels. During treatment, as many of you know in the audience, you can have some diarrhea, some food intolerances, feeling nausea, having some nausea, cramping, and some fatigue also. In terms of, GU or bladder issues, you could have some during treatment, some irritation of the bladder, even a little bit of frequency, urgency, potential like UTI-like symptoms, maybe even a little blood in the urine. And then vaginal side effects during treatment are that you could have some pain or some, various discharge or bleeding that could be even from most likely from the tumor. And then I think of it in terms of long-term side effects. So things that may occur after treatment, anywhere from 3 months to years after in your survivorship. And so long-term to the bowels, there is a risk of some bowel scarring, some, odd food intolerances. But we think, Dr. Klopp's done a lot of research in this with IMRT, or a new type of radiation technique that most of us offer. And this has decreased the bowel toxicity significantly. And now if you look at the literature, significant bowel toxicity is more in the order of like less than 10%, even some series, even less than that. So, and then long-term on the bladder, you could have some bleeding from the bladder or a decreased bladder capacity, needing to get up at night, some scarring around the bladder, and the same for the rectum, some changes in your rectal habits, or, bleeding on occasion would be rare. And then of course the very, very rare side effects of a small hole forming between the vagina, the vagina and the rectum and the bladder, called a fistula. And that is very, very unlikely. It's really in good hands. It's extremely unlikely.
Are there anything that you do in order to decrease sexual side effects after?
Yes. So in terms of sexual side effects, in women who are premenopausal, often the treatment does render you postmenopausal, unless you've had maybe a moving of your ovaries, and that can cause its own sexual side effects, the decreased libido, vaginal dryness. Even in a postmenopausal setting, radiation can cause some vaginal dryness. It can also cause some scarring or narrowing at the top of the vagina, called vaginal stenosis. and we give patients something called a vaginal dilator, which keeps the vagina open. And your doctor and nursing staff can walk you through that and help you learn to use the vaginal dilator. We actually have some research in our department right now looking at vaginal dilation, trying to make it more personalized. You know, we know that this is a major issue for our patients. It really affects quality of life. It affects personal relationships. It affects your mood, and it changes you. And you know, we really recognize that. We want to make it better.
Thank you. We can go to the next slide now. Dr. Harkenreiter, how are chemotherapy, immunotherapy, any targeted therapies used alongside radiation to help cure patients?
Right. So chemotherapy and radiation therapy are often given together. So sometimes after surgery, if you don't like what you see at the time of surgery, then patients may need radiation therapy with or without chemotherapy added. And the two work together. I describe to patients, it's kind of like 1 + 1 = 3 when it comes to attacking the tumor. When radiation and chemo are being used by themselves to try to cure the cancer, that chemotherapy has also been shown to decrease the chance of the cancer showing up somewhere else in the body. So they really work hand in hand oftentimes to kill the tumor and decrease its chances of coming back. Newer treatments like immunotherapy are being studied and have a lot of promise in a lot of tumor types. But there's significant research underway with Dr. Mayadev being really a world expert in that regard on how to combine immunotherapy with these other treatments as part of our quest to continue curing more patients.
Thank you. For time purposes, we're going to go down to there. Oh. Sure. Any of you can answer this, or Dr. Klopp in particular. Should I delay treatment for cervical cancer due to a concern of COVID-19 in the hospitals or being around people?
No, we really encourage people to go and get their concerns addressed by their healthcare team. Because definitely there's really good procedures in place in hospitals now to prevent people from giving COVID to individuals that are coming in and out of the hospital. So please definitely go in and get your needs taken care of.
Great, and then we can go to the last slide. This is ASTRO's statement on COVID-19. We have this on RT Answers as well as on the ASTRO website. We do encourage those to continue screening and their treatments. I want to thank everyone for joining us tonight. Please look at these, the brochures, the website, and this recording will be also online. Thank you.
Thank you.
Yeah, thanks so much.
Thank you, everyone.